My job really is, as John mentioned, is really to bring a couple of points. Today I'll speak this morning about inflammation, and then this afternoon or later this morning, I'll talk more about some macrobiotic changes and either using a prebiotic concept in the GI tract. So if we look really at this concept of bioactive lipids, we've now divided them into really 4 different groups. We've got eicosanoids, a classic, omega-6 pro-inflammatory fatty acids. And then you can see that sort of activate the cardinal signs of inflammation, which we need to heal. And then we go to these, which now been described, certainly the Boston group, Charlie Serhan and that group, and Jess Jolly's here today with us. Certainly then, they've discovered these to show us that these are the cardinal signs of resolution. We used to think, as John already mentioned to us, we went from thinking we just got to block the inflammation. As a surgeon for 40 years, our thought was, well, let's give something pre-op that can minimize what happens post-op. Let's minimize the amount of inflammation. Let's try to stop that inflammatory process, especially with infectious disease, of course. But that really didn't work. We couldn't really, because we don't want to stop all of it. We could, in fact, block it with monoclonal antibodies. We could block the inflammatory process, but guess what? We block the healing. Anastomosis breakdown. The healing, we never heal from infectious control. So we can't block it all. We've still got to allow normal inflammatory response, but then we need to resolve that inflammatory response. And that's really the key. And so these were discovered by Charlie Serhan and the group, these cardinal signs of resolution. Removal, relief, restoration of tissue, regeneration is really key there, and remission from that inflammatory process. But we've got some more. Recently, we've talked a little bit about the sphingolipids, they recently showed about the epigenetic role that John's talked to us about. And we've got some new, these endocannabinoids, which rapidly cross the blood-brain barrier and only recently being more talked about. So where do these so-called specialized pro-resolving molecules fit in day-to-day care? I'm still a practicing surgeon. I still take Traumacol, at least very rarely anymore. As I've gotten older, I got so many faculty now they can take the Traumacol for me, so it's not so bad. But you see, inflammation, wound healing, all these things we deal with every day. The problem is that practicing physicians are lacking knowledge in this area. There's no question. When I talk to my young residents, I talked about resolving inflammation. They go, yeah, we're going to give this pre-op. We're going to do this. I go, no, how do we resolve it after we've had an injury, after we've done surgery? And so I think it takes us about 10 years. The Boston group's been talking about it now for 10 to 15 years, and we're just now beginning to see it translating into the questions we see on their national board exams. On the ABSITE, the American Board of Surgery in-training examinations are starting to ask questions about resolution of inflammation, not just blocking inflammation like we've seen in the past. So we've known for a long time that EPA, or fish oils, EPA 20 carbon and DHA 22 carbon setting has affected all these, really since the 70s. Since we heard about this business in up in northern Norway, up in the Arctic, where these guys ate 80% of their diet was fish oil, was fat, and they didn't get atherosclerotic disease. So you question, why was that? Well, we've learned then, it must be the diet they eat. Well, they eat most basically seal blubber. And so when you see how can you get by eating 80% fat, as John said, we got caught up in this idea that fat was the culprit. So we need to in more carbohydrates, less fat. We started caught up in that, saying how can you have people that eat 60% of their calories to 70% of their calories as fat, yet don't get atherosclerotic disease. Yet we don't see inflammatory diseases. So then we thought maybe the fat type makes a difference, and that sort of started this whole revolution. So we've known for years this whole concept of all these diseases. We've got good data now. We've got solid data. When we look at the old EPA DHA, we thought this all went down through the eicosanoid pathways, preventing PGE2 and these pro-inflammatory prostaglandin derivatives. You can see to decrease inflammation immunity. That we now know was literally the tip of the iceberg. Now we know we've got all these things altering ICAM1, that's intracellular adhesion molecule 1, changes the binding, changes migration of macrophages out of the vessels into the tissues, E-selectin, toll-like receptor 4, receptor binding is altered if we have the right fat ratio around. That's the response to endotoxin, we see. Membrane fluidity, signal transduction, transmission into NF-kappa B, the on signal for inflammatory process. We can change that. We maintain its binding to its receptor. And now we know even vagal tone enhancing diaphragm function post-op with these fish oils. But the main thing we talk about recently is these ideas of SPMs, specialized pro-resolving molecules. Well, do we have data that the fish oils truly scientifically have good data to show they lower inflammation? Well, this is some great work out of Switzerland. Matt Berger and her group have shown very nice. This was a great study. They took college-age students, these volunteers, and they infused fish oil or olive oil over 1 hour intravenously. Now we have intravenous fish oil available in this country since August 2016. From the clinical setting, we can now give intravenous fish oil. Okay? 1 hour infusion fish oil versus olive oil being a non-inflammatory fat, sort of a neutral fat, omega-9 base. And then they gave, here's the kicker for these volunteers, they gave purified E. coli endotoxin. Okay, they got 2,000 euros for this study. Okay, so they must have really needed the money. Okay, so then you saw what happened here. Virtually every pro-inflammatory concept you can think, cortisol, epinephrine, norepinephrine, ACTH, all these were elevated in the group that got the olive oil versus the fish oil. So clearly showing temperatures, heart rate, all the factors, everything we look at when we look at what is hyperdynamic, we lowered the hyperdynamic ratio of people that got fish oil versus those that got olive oil. So clearly showing we can lower the inflammatory response by blocking it. But what else can we show? Well, I said, those are normal people. I remember arguing at national meetings on both sides of the Atlantic, saying this is normal people. What about clinical settings? Can it make a difference in people that are sick? Well, we then went on to look at this in cardiac bypass here. You can see almost identical response in people undergoing cardiac bypass. We load them with fish oils. We lower the metabolic response to stress, undergoing open heart bypass on a pump. And then we took Whipples. The biggest operation I do in general surgery is a Whipple. Half the pancreas, half the stomach, all the duodenum, multiple anastomoses. And we showed in that same population we could lower the metabolic response to that stress by just loading them with fish oils. And do we have data? Yeah, we have data starting back in 2011, giving an arginine fish oil combination, decrease infections. Same thing here, 2,400 patients, Annals of Surgery, our best journal, decrease infections, decrease complications, decrease in anastomotic leaks. Same thing here on GI malignancies. And look at this study. 74 studies, 7,500 patients, and now we could show that loading them with fish oils could decrease complications, infections, abdominal infections, anastomotic leaks, and now mortality. So showing there's more than just something in the fish oils, we know that they cause significant changes. But it didn't answer all of our questions. It had a lot of questions still around. Why wasn't consistent across all groups in clinical settings? Acute lung injury, cardiac rhythm stabilization. Some patients it worked, some patients it didn't seem to work. So what happened there? Was it epigenetic changes? Was it levels we didn't get to? Was it, some byproduct or some product or metabolite of the fish oil? So you think about this, you have to really look at this and say, okay, let's look at our different perspectives. And as you know, when we look in this country at Mount Rushmore, we see the president's 4 faces looking at us there. Do you ever think about what a different perspective this would be? Like, what's Canadian perception of that, right? I mean, they're looking the exact opposite, right? So we have to think about different perspectives. And as John already said to us, we sort of got lost in the idea that we can prevent inflammation, rather than saying, let's talk about resolution of inflammation. So today, this is a huge topic. Jess is going to show you some real science about this. So we'll talk about just a couple of things. Let's talk about some wound healing, infection control, etc. We know that we can load people and get levels of fish oils up. As you can see, this is nice work by Phil Calder and his group, showing that giving fish oils rapidly elevates our levels. As you can see, we come up very rapidly here and change, giving EPA at a reasonable dose, 2.1 grams. You can see pretty easy to do. So the question then, does giving fish oils up front give us a level of pro-resolving mediators, or so-called SPMs, to a level which become therapeutically accurate? This nice paper here in lipidology, clinical lipidology 2017, showed us certainly we saw the omega-3 index, so we bumped the precursor, the substrate, and now we can show the SPMs downstream increase dramatically, showing us that, in fact, when we load the patient with the fish oils, we can, in fact, get specialized pro-resolving molecules increased. So I think that's our sort of cause and effect. This work by Jess here in Critical Care Medicine, 2017, excellent paper showing us, in fact, they looked at septic patients, and they followed the serum levels within 48 hours, and at 3 days, and at 7 days. And they said, is there a correlation between a patient's ability to produce SPMs and their survival? Because that's really what we're looking for, right? Shutting off this tremendous metabolic insult and then increasing survival. That's sort of cause and effect. And in fact, they did. The resolution lipid mediators were associated with better survival and a decrease in ARDS. So I think now we've shown clearly, Jess has shown with this paper, was really the forerunner to now we can say we can start to look at these things and follow them to see how our patients are doing after a big metabolic stimuli. So let's look at a couple areas. We'll look first at gut healing. And gut healing, you know, is very complex, depending whether it's small bowel or large bowel. You can see the mucus level changes, all these cytokines changes, antigen presenting cells change levels throughout that time. But really, it's a complex, it's a balance between too much inflammation and not enough inflammation. You know, you've got to have some inflammation for the insults that the gut sees during normal everyday life, right? So we're sort of walking a tightrope, then maintain homeostasis and allow localized inflammation when it's needed, but then rapid resolution. When you think about the gut inflammation, really the gut is, it took me a long time to realize this. The gut is really the outside, right? It just happens to be traveling through us. It's just specialized epithelium there, just like our skin. It's got to protect us from the toxins, right, that is outside. When we eat things, we certainly eat enough toxin, so we've got to protect ourselves, and the gut is so specialized, it knows what it can take up and what it has to keep out. And that's the key, really, making sure you keep out the toxins while taking in all the nutrients and macronutrients and micronutrients you need to survive. And so when you think about it, there's enough endotoxin in each one of our GI tracts right now, assuming we're all healthy, to kill everybody in this room. We could take the endotoxin, isolate it from your colon, isolate it, and kill everybody here with the IV injection of that same endotoxin. It all gets septic. So the question is, we're not sick. We're all sitting here fine because we've got such a specialized epithelium. This layer above those microvilli protects us. Those villi protect us. The gut bacteria there protect us. This balance is then maintained by not too much inflammation. We know that inflammation allows a breakup of that anatomy, that allows the brush border to leave, it allows the tight junctions to break apart, and allows more to cut. For example, let's look at, we know when we sew the bowel together on a daily basis, or 2 days a week when I operate, we sew the bowel back together, and why does it not leak? It doesn't, I try to explain to my kids, it doesn't leak. They go, well, Dad, you're sewing it together with sutures, but it doesn't leak? Water, air, nothing? I go, no, it usually doesn't leak. Sometimes it does leak. 80% of the time it doesn't leak. It might be small micro leaks. But what happens if there's too much inflammation? Excessive inflammation is associated, the most important factor associated with leaks when we sew the bowel back together. We know that most of the time it doesn't leak, and so the question is, the greatest risk of anastomosis leak is during the inflammatory phase. So if the inflammatory phase sort of goes off the rails, guess what? It's going to leak, and that's, as some of you may know from relatives that have had surgery, that's a disaster. When the anastomosis leaks and you've got bowel content leaking the peritoneal cavity, sepsis ongoing, and could be mortality. So I think that's the key, controlling this inflammation. And is there data that that happens with the SPMs? Well, certainly SPMs are known to show preventing excess inflammation. Regulation of leukocyte trafficking is by the SPMs. You know, resolvin E1 inhibits TNF, stimulating NF-kappa B activation. NF-kappa B is the on signal for inflammation, so we lower that on signal. Leukotriene B4 blocks PMN transmigration, so we lower the amount of white cells that get to that site of infection. Upregulates anti-adhesive molecules and prevents activated neutrophils. Mucosal barrier repair and maintenance balances inflammatory response I talked about. Upregulates bactericidal proteins, so it kills the bacteria more aggressively if they're present. Resolvin E1 upregulates intestinal and alkaline phosphatase. That breaks down, that inactivates lipopolysaccharide endotoxin, which we know is produced by the bacteria. So it's crucial in maintaining homeostasis, transcellular biosynthesis, and resolution actively resolves. Well, what about cancer? You know, this is our growing thing, big data, new data. We've got new data on cancer coming almost on a daily basis. We've been very lucky at OHSU. We're lucky to live in Portland, where Nike is. Phil Knight just gave us $1 billion with a B to study cancer. We're building a Knight Cancer Center there, Phil Knight. And it's really allowed us to bring in huge programs. We've brought in 6 or 7 programs from MD Anderson, NCI, built them a big building, and told them go to work. So hopefully we'll be a major cancer center soon. But we've got several people there looking at inflammation associated with cancer. Okay, now what's going on there? Well, we have to first decide what's our goal in cancer. Is our goal palliative care, just to make the people comfortable? They've got unresectable cancer. Basically, let's make them comfortable. Or are we going after a curative effect? Are we going to be aggressive and try to get in there and cure the cancer? Remember, we can expect the benefits from inflammation resolution to be many. Improved tolerance to the therapy, better therapeutic response, improved quality of life, which sits over here, and improved survival if it allows us to cure more cancer by more chemotherapy or more surgery. Now, remember that 20 to 40% of cancers worldwide are thought to be from chronic inflammation. I know that sounds like a lot, but the numbers are going up. World Health Organization, you say 20%, now they're saying 40%. So I think there's no question there's an association between inflammation and cancer, okay? GI and lung cancers really are the substantial portion of those burden, okay? Activated human neutrophils are pro-inflammatory, right? And they can induce malignant transformation. So we know that activated neutrophils can produce. Here's all the cancers associated with inflammation. Just a partial list. H. pylori, a #1 carcinogen. Chronic inflammatory changes, gastric cancer. When I go overseas and do mission work, we see gastric cancer like crazy in Southeast Asia. Hepatitis C and liver cancer, papillomavirus cervical cancer, chronic cystitis bladder cancer, chronic pancreatitis pancreatic cancer. As you go down the list, scar carcinoma in the lungs, okay? Asbestosis, mesothelioma, all related to chronic inflammatory changes. So what can we do? Well, we know that inflammation is an indispensable part of the neoplastic process. Every phase of growth of a cancer, DNA damage, insensitivity to growth inhibitors, tissue invasion, sustained angiogenesis, every one of those factors related to cancer growth and development and progression can be inhibited and altered and regulated by appropriate signaling in lipid mediators. Something very important to look at. We know that just if we look back at the fish oils, we know we've known for a long time that EPA and DHA in animal models, tumor effects, decreased tumor cell proliferation, enhanced tumor apoptosis, but we didn't know the mechanism. We knew for a long time there's an association. We knew that if you had higher fish oil levels, your ability to maintain lean body tissue was better. You could tolerate more chemotherapy if you had more fish oils on board. We had no idea what the mechanism was. Until now, we know we see these resolving of inflammation molecules there. We know that the quality of life was better. This is oral supplements with omega-3 polyunsaturated fats. You can see quality of life at 3 weeks, 5 weeks, 16 weeks, and now they've got 52 weeks. But what was the mechanism? Was it decreasing inflammation? And now we believe that was, in fact, the mechanism, decreasing inflammation. Another good paper just published last month by Jess's group. He's one of numerous authors here, as you can see. A very big paper, and literally will change the way we treat cancer. What they showed here very nicely, we know that when we give chemotherapy or radiation, what happens? Some of those cells die. And when those cells die, they give off an inflammatory response. We know that the inflammatory cells that come in to clean up that debris that's left over from cancer, that stimulates cancer. Those inflammatory cells stimulate the cells that survived that chemotherapy to grow. What shows very nicely here, the debris-stimulated tumor growth inhibited by resolvins. Look at that, resolvin D1, D2, and resolvin E1 actually increase. So the endogenous clearance of tumor cell debris is a new focus for potential cancer chemotherapy. We now know that if we give that during times of chemotherapy, it cleans up around the tissue, and actually the early work in radiation shows very similar effect. So now we're not just killing the cells, we're killing the cells and cleaning up the mess, thereby decreasing the risk of more tumor growth, because we know that mess brings in inflammatory cells. So we can go down through that list again. Bioactive lipid mediators, cancer that stimulate growth. You know, they have both direct and indirect effect that we talked about, and they're implicated in every step of the neoplastic process. So the inflammatory cells are very helpful. So again, this basically says the same thing, okay? Same slide. So let's go to the last one. I'll give you a case study. A couple of you have seen this before, so forgive me for those of you that have seen this before, but it's a 63-year-old relatively healthy male with mild hypertension, talking about now inflammation of the brain. Sustains an intracranial hemorrhage, okay, at the thalamus and caudate nucleus, right at the junction of thalamus and caudate nucleus. CNS inflammation from significant bleed, okay, and right-sided hemiplegia. So the question is, we can change this guy's outcome by decreasing inflammation, right? So how do we decrease inflammation? How do we decrease inflammation of the brain? We know from the great data, and you know, this is nice data out of JAMA Neurology showing us the inflammatory process in the brain and how rapidly those tissues are destroyed. You can see we've got lots of attempts at resolution of inflammation. The main one in today's world being SPMs. These are work, but it's difficult to deliver the gaseous mediators. Some of the peptides are hard to get because you can't get them to the site of inflammation, especially in the brain, etc. Well, we know some recent work in 2017 showed us that after an injury to the brain, there's over 200 fatty acid oxidation products in the brain. And if we look at the time when these come around, remember we need the substrate of fish oils to produce these SPMs. We can show very nicely that the pro and anti-inflammatory come in within about 4 hours of brain injury. So we see it's an on switch for both pro-inflammatory and anti-inflammatory. We used to think one followed the other. We now know that switch is turned on simultaneously after brain injury. But look at this. If you have the substrate available, within 24 hours, almost all anti-inflammatory fatty acid predominate, showing us nicely that if we have the substrate, we actually will get better resolution. This answers that question which we've heard for years, is that why did people that eat more fish have better outcomes for the same stroke damage? The amount of cell death surrounding the area infarcted of a stroke did better. And there was all kinds of arguments, and I can remember the nutrition meetings for years, we talked about that. But now we know part of that, if you had the substrate, you made a lower inflammatory mediators, thereby causing less inflammation and less surrounding cell death. Okay, so resolvin D1 acts to counter the effect of ischemic reperfusion, yielding better brain tissue and neuroprotection. What about after stroke? It's the same thing. That was a wet stroke. How about a dry stroke? Well, we know in animal models, the new one, MPD1, counteracts pro-inflammatory microenvironment. Okay, stroke decreases stroke damage, PMN entering an injured brain, so inflammatory cells, induction of COX-2 and decreased NF-kappa B, pro-apoptotic pathways. So you can see, again, new data, 2017 data shows we have better survival proteins, induction of proteins, which allows cell survival after a stroke. So what can we say in summary about all this? Recent pro-resolution lipid literature offers some explanation of why we've seen for 25 years some of the better outcomes with fish oils we couldn't explain by just the fish oil, because it allowed the substrate to be available to produce a less inflammatory response. Work and routine use of SPMs be supported, or fish oils as a substrate for that, certainly preventing and resolving chronic inflammation and acute inflammation. We've seen favorable improvements in traumatic brain injury, trauma, surgery, cancer, gut mucosal inflammation, pain control, and multiple infections now. We don't have time to go into the infection data, but the infection data is fantastic, showing increased macrophage killing ability, better resolution, again, better. So we can see that resolution physiology is clearly clinically significant. That's what I was asked to discuss. Is this stuff really clinically significant, or is it just some lab thing we talk about that doesn't really make much difference clinically? Profiles will be used in personalized medicine, as John already told us. Are they clinically relevant? Back to our routine plant. Clearly, these are clinically relevant, and convincingly, they're clinically relevant. The data is overwhelming now. I look at this. I think we're here. We're standing in this light here. How much of it do we know? Only what we can see here. It's unbelievable where it's going. I think you'll see by Just Ollie's talk today, it's unbelievably fascinating how much involvement this has in numerous things. So thank you very much.